Thanks for joining me today. I'm here to tell you about our product that's the result of our STRIDE-funded research. This research focused on shared mobility options for individuals to access healthcare. And I'll present to you today different ways that municipalities and communities can structure agreements to improve access to care. So I'm going to start with why this matters. First is that shared mobility companies have been getting into the business of providing significant amounts of service to help people access healthcare. Lyft is doing this as well as Uber. These are options that are rapidly being adopted in our country, even during and through COVID. The reason that this matters is that mixing healthcare appointments leads to adverse health outcomes and can also, on the healthcare provider side, lead to more costly care. So now I'm going to present different models that can be used to improve access to healthcare using shared mobility. So to identify these, we came up with three models, but it was based on looking at 53 instances of how different communities and insurance companies and hospitals have structured their access to healthcare. We looked at different things like who is involved, how you book the trip, who pays, as well as what the benefits are. So now I'll show you and walk you through the taxonomy. So as I said, we identified three different models. The first one, which is the healthcare provider uses TNC or transportation network technology or Uber and Lyft. In these situations, the clinician often books the ride and the individuals paying could be the healthcare provider or even the patient. Examples of this are Uber Health and Ride Health. So these are often dynamic real-time systems which tend to be very easy to use for patients. So to give you some examples here so that you can understand the advantages, here's some data on Uber Health and Ride Health. And the advantages is that these types of services tend to be easier to track for both billing purposes and auditing that the individuals actually receive the type of service they should have received than some other types of providers, such as taxis. The second model is that the insurer partners with Uber or Lyft directly. A big example of that is that Blue Cross Blue Shield has some of these programs in place for all of their participants. In that case, either the insurer will generally pay if it's considered necessary to get the individual to their care. And the final part of the taxonomy is that paratransit providers, so our transit agencies, actually, instead of providing the access to care themselves through their own vehicles, partner with a Uber or Lyft to provide that service, as well as via. And so one of the more well-known examples of this is the MBTA example, where they've been shifting some of their paratransit services over to Uber and Lyft, and they keep renewing the pilot and have generally experienced shorter wait times for individuals and individuals traveling more. So I hope that gives you a sense of the different ways that shared mobility services can be used to increase access to healthcare. Thank you.